world is filled with chaos. You can either participate in it, or you can learn to calm it. The choice, my friends, is yours. So now, let's go and calm some chaos. Welcome to the chaos. I'm Tracy Canella, licensed mental health counselor with a passion for helping people find peace in a chaotic world. Today, we're going to be looking at an item that causes me a lot of chaos. And it came about because on my YouTube feed, I started getting these clips from interviews with an author and a researcher named Abigail Shrier. And Abigail Shrier has recently published a book called Bad Therapy: Why the Kids Aren't Growing Up. And there's the book. And of course, you can see I've earmarked it. I've read the whole thing. But I must say, I did not pay any of my money to buy this book because I fundamentally disagree with her on many points. And so this is going to be a reaction video on my part. And I'm going to just tell you the way it is actually happening in mental health counseling, or should be happening. I'm going to tell you what I hear. I'm going to tell you my opinion and what I know to be true about counselors. And I'm going to challenge any counselor out there who is doing anything that Ms. Shrier says that they're doing in her book to knock it off and start obeying the law and start practicing ethics. So let's get into the chaos.
We always need to ask when we see a correlation, the rise of treatment, the rise in treatment prevalence, the rise in accessibility of treatment, and the complaint malady, the disorder going up. We need to ask, is that just a coincidence? Are those two trends just coinciding? They happen to go together, but it's not that the treatment is ineffective or, as I argue, counterproductive. I don't think so. And here's why. I don't think it's an accident. There are a few reasons. First of all, whenever there's greater treatment in a population, greater accessibility for anything from breast cancer to maternal sepsis with more antibiotics, you want to see the point prevalence rates of any disease, any disorder going down, right? We want to see, the incidence of depression or anxiety in teenagers going down because we know these kids are getting flooded with treatment. Instead, it's skyrocketing. So we know at the very least, it doesn't seem to be helping. And I'm not the only one to have noticed that. A team of researchers looked into this, and they called it the treatment prevalence paradox about depression. Across the West, as people have gotten more treatment for depression, as it becomes more accessible and more available, rates of depression, especially in our young, have gone way up. Because researchers have looked into what are the common side effects of psychotherapy. We know that any intervention with the potential to help also has the capacity to harm. And that's true from everything from Tylenol to x-rays. If it has the potential to do anything at all, by definition, it can also harm. And that's true of psychotherapy too. And the known harms of psychotherapy include things like making anxiety worse, making depression worse, a feeling of inefficacy, like I can't do for myself, a feeling of demoralization. Gosh, I'm limited by this diagnosis. I can't possibly lead the life I want to live, and alienation from family members. All things that typify this generation, which is also the most treated generations.
So one of the main things Abigail says in her book is that despite the levels of mental health counseling being more available and being more accessed by people, the levels of, say, anxiety and depression in our young people are going up and not down. And you always want to see when there's a treatment applied that there's going to be a downward motion to the problem, right? And what she does is she attributes all of that to bad therapy and why the kids are not growing up. And she cites an article. See, I have the book, so I have the beauty of being able to go back into her very extensive endnotes that she writes and find out where she got the information to support this conclusion. Well, it turns out that she is citing an article from back in 2022 John Ormel, and I'm going to go ahead and show that to you now. But before I show it to you, I'm going to actually say that we therapists only spend 1 hour a week at most, sometimes more, but not commonly, with a client, with a young person, we're just going to say. And we only spend that 1 hour. And I tell them that go out into the world, apply what we have talked about in our sessions to your real life, because there's all kinds of things that can affect you. Social influences, there's social media, there's your friends, there's your families, there's your own thoughts and your conclusions. All of that stuff can affect your mental wellness, right? And so to blame therapists who only see a client 1 day a week, I think that's a stretch. I don't know what you think. Well, here is John Ormel's article, and it's just the abstract I was able to pull up online, but I did take some notes on it. So here's the article by John Ormel, and it's interesting, right? Because it says more treatment, but no less depression, the treatment prevalence paradox. And I thought it was interesting because there's not just one reason for this happening, Abigail. No, Ormel proposes 7 explanations, as you can see that I've highlighted there for TPP. And we'll just go through these and see how many actually apply to bad therapy. First, misdiagnosing distress as depression yielding more false positive diagnoses. Sure, we could do better on diagnoses, or maybe we're over pathologizing our clients. I'll go ahead and say that would be bad therapy right there. 2, an actual increase in depression incidence. So there might be an actual increase of depression. Who would have thought that? Did you actually say that in your book, Abigail? I didn't read that. But we just came out of a global pandemic. And a lot of people are wondering where they fit into this post-pandemic world. A lot of young people are struggling with identity, not just gender identity. And she talks about that later. But who they're going to be, where they're going to live, who they're going to be with as partners, and who they actually are in this post-pandemic age. And so that number 2, I don't attribute that to bad therapy. Number 3, the treatments we employ are less efficacious. All right, so what are we trained to do in graduate school, people, all you therapists out there? Cognitive behavior therapy. It's the most evidence-based way to treat a person. And it's very simple if you break it down. Think, feel, urge, do. And this process goes on for people over and over again throughout a day. There's a thought or a feeling and a thought. And then there's an urge to do something. And then there's a behavior. Most people come in wanting to change behaviors. Cognitive behavioral therapy is what everybody who has a master's degree in counseling and psychology and clinical psychology is trained to do. Now, I know how to do other therapies in addition to that, which I think are pretty cool, but that is the most evidence-based therapy that we have. You can't blame cognitive therapy if you're doing it out there for being less efficacious, right? It's not any less effective than it was when it was initially researched. Number 4, the treatments that we employ are less enduring, so they don't last as long. So they could maybe come in for 4 sessions and I can teach them some breathing techniques, calm their anxiety down, and give them some self-soothing and tools and tips, kind of like what this podcast is about, but they just aren't enduring. Well, whose fault is that? I don't know that people are actually, after they leave the therapist's office, remembering to use the tools that are taught in therapy, if you're indeed teaching tools in there. That's what I do, giving people tools to manage their lives. If they forget about it, maybe they don't come back to therapy and they just say, oh, well, my life's not working for me again. I would not say that that is the result of bad therapy. He lists number 5 as being that the trials that they do don't correlate with real world situations. And I think that's really true. That's kind of what I said about the pandemic. It's like we could do a clinical trial and we can do this research, but in the end, people are out there living their lives and being triggered by all kinds of things. And so it doesn't have to do with bad therapy being employed. It could be just because there's just a lot of stuff in the world today. Have you noticed that? There's just a lot of stuff in the world. Number 6 is a little complex, so I'll break it down for you. He is saying that one of the possible reasons for the treatment prevalence paradox is because there's either a chronic condition that's continuing to happen, which is through a long period of time, or these recurrent conditions that can maybe be resolved, and then something else happens, and then they're back again, and then something else happens, and they're fine, and then they get therapy, and then they're back again in their problems because there's new triggers. And I would have to say that that's very, very valid and fits in with my idea of that, this world is a very complex place and it's changing every day. And there's so much more in it, not just with technology, but with the people and the way that they're thinking. So, maybe I had depression and it was completely fine. The pandemic hit and it's like, oh my gosh, I'm back in my depression again because something triggered me. Or, like, all of this stuff that happened with isolation, confinement, government regulations, vaccinations, conversations with people who don't agree with you about how we should live our lives. All that stuff happened after the pandemic. So, number 6 would probably be a very good explanation, but doesn't have anything to do with bad therapy. And number 7, he says a possible reason for the treatment prevalence paradox is because that some treatments do have iatrogenic, which we'll get into a little bit more when Abigail talks about it. Iatrogenic meaning that the therapy that we employ, the good that we want to do, whether it's medical or mental health, is actually the cause of the problem that's happening. So even if we said number 1 and number 7 were due to bad therapy, there's still 5 more out there that don't have anything to do with bad therapy. So here, Abigail is saying that any therapy that has the potential to heal also has the potential to harm. That's the iatrogenic sort of thing, right? That I was just talking about. And yeah, that's true. And we have to disclose those things according to the law. In the law in Washington state, we have got to have certain things listed on our professional disclosure form. So, this form, a disclosure form, is something you give a client before they even start therapy with you. And they read it. And when they meet with you, they need to sign it, acknowledging that they understand. So, I'm going to show you a couple of different things. First, I'm going to show you the Washington state law that requires us to do this. And I'm going to show you my own page 3 of my disclosure. I have a disclosure form that's 4 pages long, but on page 3, I do disclose this because I try and obey the law. So if you're a counselor out there and you do not put in your disclosure that this therapy thing that you're doing has the potential to cause harm, you do need to put that in your disclosure because they do need to know that it does have the potential to cause harm. So here are my documents. So this is WAC. That is the Washington Administrative Code 246-810-031. All of these items need to be in our disclosures. So therapists out there in Washington state, see if your disclosure is whack, all right? Or if it's whack, it's actually a good thing, right? Because you're in compliance with the whack. And I don't know why I'm really liking saying whack right now, but I am. So there you go. So number 2, you see how I circled 2 because you got all these subsections, and then there's K, and then there's these little 2 dots right here that says credentialing of an individual with the Department of Health does not include a recognition of any practice standards, nor necessarily imply the effectiveness of any treatment. You've got to put that in your disclosure. I know that all states have laws, and counselors in all states have to look at the law, again, the law and ethics, and I'll go into the ethics a little bit later. But this is the law in Washington state as far as what we are supposed to disclose to our clients before they even meet with us. And so, if you're doing your job right and you're not a bad therapist, as she said, I don't even think you're a bad therapist. Maybe you're just not informed. Maybe you didn't have a great supervisor. I don't know what's going on out there. I do want to find out, though. You do need to disclose it. So I'm going to show you a copy of my disclosure form just to prove to you that I actually say that. And I think I worded it pretty eloquently here. All right, so this is the top of page 3 of my disclosure form, and I put some arrows there. So you can see in the first paragraph on page 3, it says informed consent and feedback. And where I underlined at was although there are risks in any of the treatment methods I employ, including failure to relieve emotional distress, it is also true that failure to receive treatment can lead to risks, including continued emotional distress. I thought that was a lovely way to say, you know what? Counseling doesn't always work. And if it doesn't work, we're going to figure out what is going to work for you. That's part of the counselor's job. Now, you'll notice I have another arrow pointing to the third paragraph. And what it says is if you believe that an act I have committed is unprofessional, I strongly encourage you to talk with me about your concerns. If having done this, you feel your concerns are still unresolved, you have a right to notify the Washington State Department of Health. And I give their phone number. And you can also call the American Counseling Association. And since I am certified as a CRC under the Commission on Rehabilitation Counseling, you can also call the CRCC. You could probably call IADEP. I mean, you could probably call any of these governing boards and say, hey, I want to complain about Tracy Canella. She's doing bad therapy. Now, this is the oversight that governs our disclosure forms. There's an actual law within a law, right? So this WAC 246 809 720 says failure to provide client disclosure information under this other WAC that I just read constitutes an act of unprofessional conduct. So you probably need to look at your disclosure form and make sure that you have all of those elements of your disclosure form on there if you're a counselor. And if you're a client, please read the disclosure form. Some clients are like, oh my gosh, I just don't have time to read 4 pages of this stuff, right? And they just sign it. And I know that goes on out there. So what I do as a counselor is I ask them, have you read it? Do you have any questions? Do you understand? Because I'm going to need you to sign it. And they'll sometimes have questions and sometimes they'll say, I didn't read it. If they say I didn't read it, I will actually take time in the session to go through that with them because it's important to have them know who you are and what kind of counseling they're getting into. It's sort of like when you buy a used car and it says as is and it has all these things that are on the vehicle. I guess they have that in new cars as well. But that's what a disclosure form is. It's this is what you're getting. Do you want it or not? If you do, sign your name. If you don't, let's refer you to someone else.
Start the book by separating between two groups of people: the severely mentally ill, those with a real mental disorder who are undertreated and underserved, certainly in America, by a large margin. These people are not getting the help they need. And then we have what has been called the worried well. These people don't suffer in a profound way. They are sort of the bummed out teens of the West. They're fearful, they're worried, they're sad, but they don't have major depressive disorder, and we're reluctant to diagnose them with that. There is an expansion in mental disorder in diagnosis. There's no question. Way more people, young people, are being diagnosed with things like ADHD, depression, anxiety, and whatnot. But mostly those aren't people who are profoundly hampered by mental illness. Mostly it's people who are a little, extra worried. Or, but let's take the severely depressed for a moment. These are people whose lives are so profoundly affected that they can't get out of bed, that they are truly suffering in a way that they can't function otherwise. That is not the population I'm talking about. Those people need all the resources we can give them. But mostly, I'm talking about people who just feel like they need a mental health day off work. They don't even usually say they have mental illness, although these young people are quick to state their disorder, but they'll just say, I need it for my mental health. Not that I have mental illness, but that this would be good to boost me. And that's what we're doing. We're assigning preventive care, so-called preventive care, which has never worked successfully in mental health, preventive care to a population that is well. I'm not minimizing the actual conditions which people do have. What I'm saying is, we aren't all, I'm disputing the idea that we're all a little mentally ill. Now, it is true that the rising generation describes themselves that way. They seem to believe we're all on this big continuum of mental illness where the serious schizophrenic is on one side and I'm just a little to the right of that. That's actually not true. Schizophrenia is a profound illness that is very difficult to deal with, and the bummed out teenager doesn't have a little bit of it.
When we talk about the severely mentally ill over here and the worried well over here, it is a continuum. Like most things are a continuum. When you think about safety and risk, in your behaviors, or you think of complete and total trust and paranoia, most things do exist on a continuum. I think we've gotten into an age now that we're thinking it's either there or there, when actually things do exist on a continuum. And by the way, if you are just a little worried or a little stressed out, that doesn't mean that a little therapy can't help, but that does need to be goal directed, and it needs to have a treatment plan format. This is the way I was trained as a clinical therapist, and that is to have a treatment plan. Now, I'm going to show you my treatment plan format. It's by no means genius, but I developed it, and it's been serving me well for the last 15 years as I've been doing private practice counseling. It's been great. And so here's what a treatment plan looks like, and it really keeps you focused on there is a problem and there is a goal and there's other things. So let me show you my treatment plan. So it's pretty straightforward. You have a problem, the first column here, or you could have 3, you could have 1, you could have 3. We could get another piece of paper and you could have 12. I don't know how many problems you would have, but a problem, let's just say, because Abigail alludes to it, anxiety. And so you might have a problem, anxiety and depression, right? I'm anxious and I'm depressed. And so what's your functioning? Anxious. Okay. I start to panic. I start to sweat. My heart beats very rapidly. I can't find my words, kind of like what I'm doing right now. All these symptoms of anxiety that you can't go to social functions, right? So you write that in there. Depression, same thing. I'm depressed, can't get out of bed, can't work, all that stuff. What is the goal? What do they want to see happen? That goes into this section. And then as they are talking, I will write some ideas. Usually it's CBT, cognitive behavioral therapy, as I've mentioned before, or dialectical behavior therapy, which is just as good and just as evidence-based, but not everybody's trained in it, and they don't typically teach it in graduate programs unless things have changed. Maybe they have, it's been a while for me being in graduate school. And we would want to maybe sometimes in some cases for them to get medical lab tests, depending on what they're struggling with. We want to have some ideas. And I make it clear, you don't have to do anything that I say or that's not comfortable, but these are just ideas so that we can kind of bounce them around. And the ones you want to try, let's try. And the ones you don't feel comfortable with, let's not go there. I never pressure clients to do anything they don't want to do. So that's my treatment plan. And it's an accountability tool where I will say, if it's really affecting your functioning, on a 0 to 10 level of distress, 0 meaning no distress at all, and 10 meaning like you're having, a lot of distress. It's a very, very high level of distress. I want to know if you're an 8. If we review this treatment plan after you've been in therapy, you should be down. Right? That's exactly, I agree with Abigail with that point, that it should be down. This is why we have treatment planning. This is why we take the assessment of functioning and we hope it goes down. If it's not going down, we need to do something different. And if we're not doing something different, then we might be doing bad therapy. She talks a little bit more about this kind of thing later on. And so remember the treatment plan for when she starts to talk about us keeping people in therapy purposely without anybody having a problem. So to illustrate what counselors have to do to assess how severe it is and that things do exist on a continuum, we have a tool that's called the Global Assessment of Functioning, or the GAF. So what's your GAF, right? So where are you at? And I'll show you the GAF scale right now. Every time you see a client, you need to provide global assessment of functioning. So if you can see here, You've got code 191 to 100 is superior functioning. I never see, you just don't see people with gaffes of 91 to 100 in a counseling office. And even 81 to 90, absent or minimal symptoms. You just don't see that. When you get into the 80s, the symptoms might be present. 71 to 80, symptoms are present, but they're transient. And that's kind of what they were talking about, maybe recurrent or situational. 80 to 71. Then 61 to 70, some mild symptoms or some difficulty in social, occupational, or school functioning, those life domains that you have. So there's some in there. 51 to 60 is moderate symptoms, flat affect, or difficulty, moderate difficulty. So it's not mild, it's moderate. So you see this whole continuum. 41 to 50, serious symptoms, suicidal ideation, severe obsessional rituals. Now, this happens a lot with eating disorders. They come in with these severe symptoms, and we need to assess whether we can treat them with an outpatient setting, counseling office, one visit a week, or whether we need to refer them up to a higher level of care. We look at their global assessment of functioning there. And then when you get 31 to 40, there's impairment in reality testing or a major impairment that needs definitely a higher level of care, hospitalization. You get from 21 to 30. So, see, this is proof that there is a continuum of mild and of severe mental distress. So she's not right on that point. She tries to tell the interviewer of Unheard that no, it doesn't exist on a continuum. It's either you're sick or you're well, and that is simply not the case.
Do kids need support? All kids need support, of course, including kids who've been through something very traumatic. They may need special kinds of support. There's no question, depending on what they've lived through. But two things. One, should we presume that most kids will be traumatized by a tough upbringing? No, actually, we should presume the reverse. Most kids are remarkably resilient in the face of adversity. Two, is there proof that kids who've been, say, physically abused are more likely to abuse their own children? Actually, no. In prospective studies, meaning forward facing studies, which are the only rigorous ones, where you start with the kids where they're children. Kathy Wydham did this, a wonderful researcher. She started with the kids who were actually children. She documented their abuse, so we have proof of it. And then she caught up with them 15 and 20 and 30 years later. And it turned out they were no more likely to abuse their own children.
So Abigail says some interesting things in this clip. First, she says that should we presume a kid would be traumatized by a tough upbringing? And her answer is no. And I agree with her, actually. We should not presume anything. But we have to listen to the kids' lived experience and how it did affect them. And we do have to take their concerns seriously. We really do, because when you look back at people who are doing these mass shootings and acting out in ways that are societally unsafe for us, it often goes back to a traumatic history. We're not going to fish for trauma, but if we hear a story that you think might be a traumatic sort of an event, then you do want to ask questions about it. So yeah, I do agree we shouldn't presume, but we should ask. We should be curious when a story starts to feel traumatic. Secondly, she says, is there proof that people who are abused will abuse? And she said, no. What she's saying is there proof that, because you're abused, you will abuse? I don't know. I don't know what the answer is. I don't know what the research says on that, but I do know this. I've been in private practice counseling for 15 years, and every client I've ever seen, I've done a genogram on. And a genogram is just a family history. And you can see by the family history that it does intergenerationally transmit to generations after generations until, hopefully, with the client I'm seeing, it will stop and it won't be transmitted anymore. I've just continued to see it on all of my genograms that I've done. So no, I'm not basing this on research. I'm basing it on 15 years of doing genograms and seeing trauma continue to go downhill. So that's what I have to say about that.
Let me just talk about therapy for a second.
Whoa, can you hear the disdain in her voice? I'm surprised she didn't spit at the camera.
I wrote an entire book, obviously, about the irreversible damage, about the transgender epidemic, about teenage girls. And what I want people to know is in almost every case, the girl who was sent to a therapist by her parents, not for gender dysphoria, but for anxiety or depression, in almost every case, the therapist participated and encouraged, the young teen's revelation that she was transgender. Because what they were doing in psychodynamic psychotherapy while they were exploring, the young girl's alleged trauma, when they were done talking about mom, they would move on to gender. So, how are you feeling about gender? And together they would come upon this diagnosis. So, before we even get to medication, there are very real ways in which therapy can make your problems worse or introduce new problems. That's what bad therapy is.
Here she starts to talk about therapists and when they're dropped off for anxiety or depression, then they get started talking about gender, and then gender filters into the diagnosis, kind of like there's a big conspiracy here. And that if that's happening, that's not, I mean, we do, if they say my pronouns are they, them, we want to honor that as best as we can. I can't say I'm perfect at it, if a person presents as feminine and they're saying they, them, it's hard to adjust for me anyway, but I do my best and I try, but it's not like I'm trying to manipulate an anxiety client into a gender dysphoria client. I mean, if you're doing that out there, therapists, please don't. I mean, if that is something that you think is at the heart of every problem, it's not. But she talks about all this stuff using data from her first book, which, by the way, I'm not even going to buy with a gift card from anybody. I'm not even going to do that. I don't know what her sources are because it's in that other book that I don't own. But it would be great if she cited her sources on the interview, and she did not. And so I really don't know what the answer is, but if you are dropping your kid off to therapy for anxiety and they come back with a gender issue, it might be because their anxiety was about gender in the first place. But I'm not sure that what we're doing as therapists are trying to find a gender problem for an anxiety issue. We might ask about it. We might ask if we see some sort of a clue. Um, if they mention it, of course, we want to explore it with them. Any therapist who's fishing for a diagnosis of gender dysphoria in an anxiety client or a client who presents with an anxiety, especially a young person, then we need to examine our codes of ethical conduct. And I'll go through them briefly right now because the code of ethics is pretty long, but everybody has them. And this is something you definitely should not be doing. Again, we talked about the law, and this is ethics now. So as you can see in the Code of Ethics, this is 24 pages long, and this is the second page of it, I believe, or page 3, where it goes into the big 6 ethical principles. Autonomy, which is when we let the client decide for themselves what is right and true for them, that we don't decide that they decide it. Non-maleficence and beneficence are 2 and 3. So non-maleficence do no harm, and beneficence is to do good. Justice, which is treating individuals equitably and fostering equality. Fidelity is honoring and keeping our promises to our clients. And veracity, which is to tell the truth. So in that example that Abigail gave about dropping a kid off to therapy who has anxiety and we're asking them about gender and away goes a gender diagnosis, that's not fostering patient autonomy, and it may actually violate some other one of those things too. We're not trying to do beneficence, we're not trying to do good, we're trying to create a problem where there isn't one. If you're doing that and you're a therapist, I would strongly rethink that and read the codes of ethics. You have a lot of processes and procedures. This is an important one here in this paragraph that I'm hoping that you'll see. But When counselors are faced with ethical dilemmas that are difficult to resolve, they're expected to engage in a carefully considered ethical decision making process and consulting with available resources, including the American Counseling Association. If you're a member, you get free ethical consults. So, this stuff is all written down in ethics. So, if there's bad therapists out there, there could be, and maybe there are. I want to be able to help make better therapists out there. I don't know how I'm gonna do that. Maybe that's why this video was so important to me to redo because I think the message is for therapists, really. Maybe my regular viewers have viewed it as well, but I really want the therapists to hear this.
A teenager who shows up in a therapist's office, it's because her parents made her. So the therapist has to work to get her in a way that she doesn't that a therapist doesn't need to with an adult. But there's something else too. A child doesn't have the life experience of an adult. It's very hard for a child to say to an adult, listen, I'm not sure we should be calling my parents toxic.
In this clip, Abigail says that a therapy is either making new problems or making existing problems worse. And okay, if that's happening, then therapists out there, please do not do this. Take a continuing education program in ethics, get trained to do different kinds of therapies that can help anything, okay? Because we don't want what is in this book to be true, or at least I don't. So she talks about the case of a teenager showing up in a therapist's office because her parents made her. And while that is certainly true, there are plenty of teenagers who want therapy and their parents don't want to give them therapy. And a good example of that is Ethan Crumbley, the person who shot up the Oxford High School, and he killed 4 students there and shot and wounded a lot more. And now he's in prison for the rest of his life, likely. And so, he wanted therapy and his parents didn't give it to him. That's one of the reasons why his parents are also in prison and will be for at least the next 15 years unless their appeals go through. But I digress. There are plenty of teens who want therapy. And there are plenty of teens who want therapy and their parents are giving it to them. There are plenty of teens that want therapy and their parents don't want to give it to them, but they do anyway. And there are plenty of teens who try and get it on their own through either the school or another system that they can get help with.
How does patient therapist confidentiality work in the context of having a child patient? I've always kind of wanted to know.
I'm not sure I totally understand it because there's a lot of wiggle room here. I know that that patients that the confidentiality seems to be between the therapist and the child, but a lot of the information gets leaked to parents. Parents often use the therapist, and they told me this to kind of surveil the child. Like, can you make sure nothing bad is going on?
So
She
kind of
won't talk to
helicopter
me.
parenting, but
Yes.
set to a
Yes.
thousand.
Yes, exactly. So often that seems to be how it's working in practice.
So in this clip, the host of Unheard asks Abigail, well, how does patient therapist confidentiality work with a teenager? And Abigail actually says that she doesn't know. So I thought I would explain it to you. Okay, so here's how it works. In the state of Washington, 13 years of age is considered an adult. And so that means the 13-year-old gets to sign all the paperwork, gets to receive the disclosure information, and that's why we need to be extra careful to explain things to them. And they also need a release of information for me to talk to the parents. And I always encourage them to sign it. And I tell them I will only tell them what I'm going to tell them before talking to you. If it's a safety issue, if it's an issue that they're going to need to attend to, usually my teen clients, especially at 13 years old, they're not going to want to pay the bills. They're not going to want to answer insurance company questions. They're not going to want to call the insurance company and all that stuff. Parents need to do that. They don't know how to drive themselves to sessions, so the parents are going to have to be involved in some level, even when they're considered an adult at 13. When you're under the age of 13 and you're still considered a child under therapy, then all the parents have to sign all the papers and they're involved in the sessions. Or if they aren't involved in the session, it might be just the last part of it that I could talk with the client, the 12-year-old or under, by themselves. Now, I don't treat clients under the age of 13 because it becomes very complicated in my mind who is in charge of the file. If it's let me make it really simple. Who's in charge of the client's file? When you're an adult, 13 and up, you are in charge of it. When you are under the age of 13, your parent is in charge of it. And so your parent is kept in the loop on everything, and we do therapy together. It's sort of like family therapy. You could do therapy with a person under the age of 13 without a parent present. I don't tend to like to do that. And that's one of the big reasons why I only treat people ages 13 and up, is because it, in my mind, gets too complicated. If there's family therapy going on and the parent is going to agree to be in every session, I'll definitely do that. And if there's an issue that the person who is under 13 wants to talk about without their parent, then we need to decide together whether it's a safety issue and whether the parent needs to be involved, or if it's just some thoughts that they're having that they don't want their parent to be aware of that aren't safety concerns. Again, it goes back to the law and ethics. We have to apply them to our children, and we have to apply them to our children clients and to our adult clients who are 13 and up, right? 13 is considered an adult in the state of Washington, as I said. In many states, it is 18, and that seems a little bit more appropriate, but for some reason, we have it as age 13 in this state. So that's the way it is.
Now, remember, when you drop your child off to a therapist, the therapist's job is to be non-judgmental. That's something we want as adults. We don't want a therapist judging our life decisions. We want help with the things we need help with. But with a child, dropping your child off for a non-judgmental adult's assessment of her life, who might say, oh, you're having sex with, at 12, that doesn't seem to be like a good idea. You don't want non-judgmental with a child unless you absolutely need it again. And that's where that's where we're seeing so much mischief being made. A lot of parents who wrote the last book about, who thought they were dropping off a very, anxious or nervous or sad teenager with a trusted adult. They thought the adult could just be trusted to sort things out for her. I don't think in almost any case, and I talked to almost 1,000 parents by the end, I don't think in any case I heard the therapist told my daughter, nope, you're not transgender. You're just 12.
So remember when we were just talking about the 12-year-old? Oh my gosh. So then Abigail gives this example of a 12-year-old who's in a counseling office for something, and she happens to mention that she's having sex. And then Abigail says, you want adult clients, you want the therapist to be non-judgmental, and you want in child clients, you want the therapist to be judgmental. And so what does she want me to do? Say, stop having sex? Well, I actually can warn that child that it is against the law at her age. The age of consent is not 12. And so I can say that, you realize that. And then it also becomes a safety issue that I have to ask, all right, how are we going to tell your parents about this? And so it gets a little sticky. When you're 12, the parent, again, is in charge of the client file. So the example that she's giving and the thing that she's implying about therapists, like not just being completely non-judgmental about a 12-year-old who's having sex. No, we can't do that. Legally or ethically, we can't do that. And so if you're doing that, people, clinical therapists, social workers, psychologists, whoever you are out there, please don't do that. Please obey the law. Please have ethical conduct, because if this kind of stuff is going on, I'm getting all fired up. I feel like my armpits are getting all sweaty here. It's like really getting hot in this room right now. So don't do that, please. Do good therapy and do a treatment plan. Oh my gosh, I feel like I'm yelling at you guys. I am so sorry I'm yelling at you, but this is just the passion that I have. Later on in this clip, she says something about interviewing 1,000 parents. And I thought about that. And actually my husband brought this point up to me because he's a good math guy. But okay, let's just do the math on this. You've interviewed 1,000 parents? You know, I've tried to have a 20-minute phone call with a parent. It's almost impossible. They want to talk and talk and talk about their kids, right? But say, for the sake of argument, each of these conversations you're having or interviews you're having with these parents is 20 minutes, right? That's 333 hours total that you're talking, which translates into maybe 6 hours a week for a year. Where are you getting that time and who are these parents? Even if they're 5-minute conversations, it's going to be 83 hours. 83 hours total, 2 hours a week for a year. I don't get where she's getting these interviews or doing them, and 1,000 of them. That's a lot. Okay, so I feel like maybe she is exaggerating here, and I don't have any citations to back that up. And because she didn't put like met with blah 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 for this amount of time, and then she adds them all up. I don't know. I don't have that data, but I don't believe that it's true. And then what she says about you're not trans, you're just 12. How condescending and invalidating. I wonder what her kids are going to turn out like because she does have them. So now Abigail also did an interview with Joe Rogan, which is actually her second interview with him because I guess the first interview she did with her first book that she had written, I think it got pulled off by Spotify or something. It got pulled off or banned or something. Anyway, they are fine with it. They met again and they're doing this second interview and they're talking about the same topics, but a little bit different tone. And so here is the first clip of the Joe Rogan experience with Abigail Shrier.
It's weird because as a parent, like you want to hear kids out. And when they're having like some sort of anxiety and issue, you want to talk with them and you want to talk through it. And you want to you don't want to tell them, hey, you're going to have to suck it up. I never say that. And I probably should. I mean, I don't know if I should. But I mean, if I had boys, I probably would. I think I would probably treat them differently. But I think that there's there's a fine line. Like,
Yeah.
where is the point of diminishing returns? Like, where is it valuable to address feelings and anxiety and thoughts? And is it irresponsible to do so without giving them tools to mitigate those things? And along with those tools, to explain to them that there's things that they're going to have to do in this life that are very difficult,
Right.
but that there's a great reward in doing these very difficult things.
So the problem, as I see it, is not that you're not saying suck it up. It's that no one ever says suck it up, no matter how minor the scratch to these kids. Okay.
Mm,
And sometimes being told you'll live. Remember when
yeah.
dad used to say you'll live
Uh-huh.
or, shake it off? We never hear shake it off anymore. No
Mhm.
one says it. So they don't know they can overcome even minor injuries. And the truth is they can.
No one ever says, suck it up, buttercup. No one ever says, you'll live or shake it off, according to Abigail in this clip. You're right. And nobody's saying it. And they don't even know their own resilience, all this other stuff. Shake it off. Okay. Well, the reason that these things aren't being said anymore is because it is invalidating. We are not hearing our young people when they're having struggles. We're not taking them seriously. And we are telling them to just suck it up. I 100% agree that everybody has resilience out there, and especially our young kids. I do. I agree with her on that point. And I also think we need to be listening when they start to tell us their concerns and taking them seriously. Because if you say you'll live, well, in a child's mind, maybe they're defiant and they'll say, well, no, I'm not. And they could end their own lives. We have a lot of people, young people, who are choosing to end their own lives. And I don't know if that's wise because people saying you'll live, but that's definitely triggering in the mind of a child. And so when you're saying that, you're very much invalidating their experience. And so I think that's why it's not being said anymore. We're trying to be more sensitive. But if we take again the continuum, almost everything exists on a continuum. If we take sensitivity over here and a complete apathy or callousness over here, then we gotta reach a middle ground. And for each child, it's different. Do you care about your child? If you do, find their middle ground. Okay, your middle ground as a parent, and where you're validating them, but also holding them accountable and talking about their own resilience. And so I need to disclose that I am actually not a parent, and probably because it is one of the toughest, if not the toughest jobs in the whole world. But we need to strike that balance between, like, we don't want to be enabling them and overly validating them, but we don't want to be uh, saying stuff like "suck it up, buttercup," and being invalidating. We do need to find a balance to where the child is learning resilience and doing the things that they know that they can do. I like to say that everybody has their own unique talents, strengths, and gifts to offer to the world. We just need to find yours, and it's in there somewhere, and we're going to find it together. And I think I would say that if I had my own child. And so I think that, again, parenting is a very hard balance, but if you care enough about your child, you'll make the effort to get there.
Did you talk to therapists when you did this?
Yeah, a lot of therapists.
Yeah. How many of them agree with you?
So there was a huge split. The academic research psychologists overwhelmingly agreed. They were aware of the literature and they said, yeah, these are bad practices. Here are things we shouldn't be doing with kids. What was interesting is a lot of the clinical therapists were either minimized the risks of therapy or denied that there were any.
Mm. But isn't that like Jiffy Lube? Like when you tell them you don't need to change your oil that much. Well, it's their business to change oil.
Right. Exactly. Exactly. So, like, I talked to this one amazing, child psychologist who said to me, I start by having my patients sign a waiver in which they acknowledge that there can be risks. And the reason I would do that is because I don't want them to experience harm. So, if they see that their worries are getting worse, they have to tell me.
Now, here Joe Rogan asks, did you talk to therapists when you did this research? And she said she talked to many of them, and they were split into the academics and the psychologists and the academia. They sort of got it. But the clinical licensed mental health counselors and social workers like me, they just didn't believe that the iatrogenics or any harms in therapy could happen. They didn't believe it, right? And I'm telling you that it's somewhere in the middle. I believe some of what she says is true, and if bad therapy is going on out there, it needs to stop. But the way she sort of partitions us both out, it makes me feel a little icky, like she's staff splitting there, if you know what that is. And so she says that her esteemed psychologist friend has his clients sign a waiver that discloses the harms of therapy. No, it's not a waiver, sister. It's a disclosure form that I've already talked to you about, and we're supposed to do that by law, as I've already illustrated.
I mean, it seems like the therapist is the one who's in control, right?
Right.
The therapist is the expert. They're the one who has the authority.
Right. Well, I mean, this one was Camilo Ortiz was one of the, he was the one I talked to and the one that I was referring to there. And first of all, he always starts a therapy by setting the number of sessions. It's not, he doesn't treat a kid like an annuity. You're going to, be my income stream for years.
I don't number my sessions, but I do say this, and it's not in my disclosure form, but I tell all my clients this. If something does not change after 4 sessions, we need to revisit the kind of treatment that we're doing or the level of care that you're receiving. Something's got to change or shift in 4 sessions, or we need to change our game plan. It's not that this psychologist that she mentions in this interview is so special. It's just that this psychologist is obeying the law and is doing things ethically. And we all need to be doing that if we're in these helping professions. And then she says that therapists want to treat their clients as an annuity. Like, we want to keep them sick so that we can continue to have this gravy train of money coming in while the client doesn't get any better. And I just say, what? This is where the treatment plan comes in again. This is where law and ethics come back in again. If any bad therapy is going on out there and you're doing it, you don't have to confess to me at all. Just in your own mind, make the change into good therapy. Because if this stuff is going on out there, it shouldn't be going on. And there is oversight There's the right, if you are a consumer of therapy, to complain, which I will show you the complaint process in Washington state, and they have it in every state. You can complain about your therapist if you believe that the therapist is acting unethically or illegally. So you have the right to complain. The consumer has the right to complain and get results. That's how bad therapy is going to stop. And that's what I do as part of my work is with the Department of Health in complaint investigations is they'll give me a case and I will look into it. I'll read into the notes and I'll see if any bad therapy is going on. But we wouldn't know that unless somebody complains. So please complain about your therapist if you think something is wrong. Some of these complaints are unfounded, so please don't complain lightly. Some of them are unfounded, some of them are egregious, and some of them are, there's a couple of violations or continuing education that's needed. But here is the complaint process in Washington state. If you have a problem with your counselor, there's oversight. Trust me. So on the Washington State Department of Health, there is a section about how do I frequently asked questions. And this one says, how do I file a complaint? There are plenty of ways that you can file a complaint. There's online, and here's the intake form. You begin, and then it's very easy to file a complaint. So you can send an email, or you could just follow the directions on the screen and do it online. It's fairly easy to do that in this state. And so please, that's how oversight is going to happen, is if we're aware of the problem.
Also, the incentive is for therapists to treat the least sick for the longest period of time. That's the incentive.
Yeah.
Because you don't want the schizophrenic patient who really needs you.
Right.
They're really hard to treat,
Almost impossible.
almost impossible, right? You don't want the bipolar patient.
Right.
Some people will refuse to see those patients. But a teenager with a little social anxiety, parent pays on time, they're not getting violent in your session.
Oh boy. Wow.
So in this section, Abigail talks about that therapists are treating the least ill for the longest period of time, and we're ignoring the severe needs of other people who have like schizophrenia, or they have bipolar disorder, or they have an eating disorder. And she says that we're maybe trying to oversimplify it. And yeah, we get in private practice anyway, we get to accept people who are within our level of competency to treat. So maybe some people aren't trained to treat schizophrenia or eating disorders or bipolar disorders. They have not had that training. They could get it. And really, ethically, if you do get somebody that you can take and they have bipolar disorder or they have trauma or something like that, then you are ethically encouraged to seek consultation to support that client. So you get to learn something as a therapist, or you take a class and you get familiar with treating bipolar disorder. I remember my first case of gender dysphoria came across, and I disclosed, of course, to the person that I don't do this work. And they're like, I don't care. I still want to have you as my counselor. And I said, I'm going to have to receive some consultation about that. And I'll do everything possible to keep your confidentiality, because that's what we do in consultation. And that person was completely fine with it. In fact, they ended up assigning a release of information form, which I thought was really super cool. And I was able to consult, and I was able to learn something and help this person. It's a great story. I'm also a certified eating disorder specialist. And, when we talk about chronic illness, eating disorders, about 6.5 years of treatment is about the average that you're going to see. Some of them resolve in less time. Some of them take longer. Some of them are in treatment and therapy all of their lives, and they don't get any better, which is sad. In fact, the eating disorder anorexia nervosa has the highest mortality rate in the DSM-5 TR. And it's still true to this day. About a third of people die from the disorder, a third struggle on and off through the rest of their lives, and a third recover. I treat them anyway, right? So I'm out there in the trenches, guys. I am not shirking my duties. And I would encourage any therapist out there who wants to, maybe just push themselves to learn something new and to treat a new population or to specialize in something, to consider treating eating disorders. It's a really, really interesting field. No eating disorder is the same. None of it started the same. None of it manifests the same, and no recovery is the same. And I think that's a beautiful thing, and it keeps everything alive, fresh, and new in my own mind. And so I have a balanced practice where I treat eating disorders and I also treat anxiety and depression and relationship issues in my practice. And I think it's pretty balanced, but that's up to the therapist to balance their practice. It's not like I'm just trying to take the easy anxiety clients. When one comes my way, I'm thinking, great, 4 sessions, this person's going to be feeling a lot better. And that makes me feel better. So in conclusion, here is the book called Bad Therapy. Please do not buy it because I've just pretty much summarized it for you. And if you want to buy it, great. More power to you. I wouldn't recommend it. What I would recommend is that you buy this book instead, which is by Lori Gottlieb. Maybe you should talk to someone. This book, and this book I did not power through like I did with Bad Therapy. This book, as you can see, I'm about halfway through it, and the reason why I'm halfway through it is because I want to savor it. It is such a good read. Not only is it funny, it's relatable, but it's a therapist's own experience, not just as a therapist, but as also a client of therapy because something happens in her life that she needs therapy for. And she talks about her clients. And what I want to say about this book that Abigail didn't put anything about who she interviewed and how confidential that information was. But in this book, she writes about a beautiful phrase that said, "The relationships I write about here between therapists and patients require a sacred trust for any change to occur. In addition to attaining written permission, I have gone to great lengths to disguise identities and any recognizable details, and in some instances, material and scenarios from a few patients have been attributed to one." She tells you exactly what she does and she gets permission. This is an ethical counselor. The other cool thing about this book is it not only talks about her problems and her clients in therapy, but she really gives a lot of factual information about how therapists do their jobs. It's a very good read. I would highly recommend this book. So I don't even need to review it. I love it. It's wonderful. I'm savoring it. And I hope this has been informative for you. I just want to thank you for listening to Calming the Chaos podcast. I never believed I have almost 500 subscribers, and that means that you're listening to the content and enjoying it, and I'm going to try and make it a little bit different and hopefully more informative and enjoyable for you. And so my wish to you as we're departing is that all therapy you receive is good therapy. And I wish you a nice calm through your chaos. Take care. Thanks for joining me on Calming the Chaos. If you've calmed your chaos today, then that's great. And if not, well, there's always tomorrow or the next day. Thanks for listening and take care.